Hey guys, today we will be covering critical neurological illnesses. Particularly today's content will be related to covering traumatic brain injuries. So the objectives for today are listed here. So make sure that you go back and you read over the objectives and answer your objectives. So we're going to be prioritizing care for traumatic brain injuries. We're going to be talking about who else is going to be on our team with brain injuries. So make sure you go back, like I said, just kind of starting you out with those objectives and make sure that you're prepared to answer them so you can be adequately prepared for your exam. So let's think about what actually is a traumatic brain injury. Traumatic brain injuries have to come from a force outside the head. So it's not going to be from like the stroke and that kind of thing. That's not the traumatic brain injury. Traumatic means outside the head. These patients can have either some temporary loss or some permanent cognitive damage. They can be physical or psychosocial function problems that can either be temporary or permanent. In an acceleration-deceleration injury, you may have covered this in your pediatric course with shaken baby syndrome. This is when the head movement during acceleration makes the head hit the back of the skull, and then when the stop of the head actually hits the front of the skull. And if you think about it, you're going to have an injury to the front and back of the skull in these types of situations. So brain injuries can be where they only affect one particular part of the brain, and that will be considered a focal injury. And these are injuries that are happening at the time of the injury. So initially, the patient just say has an injury to one area of the brain. That would be focal. Or they can have an area that is really spread out to multiple areas of the brain. These kind usually aren't detected on a CT scan. They would be better seen on an MRI. So when you're thinking about what test to do, if it were focal, we'll pick it up pretty quick on the CT, but if it's diffuse, MRI would be a better option. For an open traumatic brain injury, basically in this, the skull has actually been compromised, so it's been fractured or there was a penetrating object that went through the skull. So in these, you have to really worry about the patient may have some infection. In the closed traumatic injury, the skull's not compromised, so it was the brain was damaged either by force or the movement of the brain in that cavity rubbing against the internal bone. So how will we know, like, how bad is this brain injury? Is it bad enough we need to keep them in the hospital? Do we need to send them home? Do they need to just stay overnight? How we determine the severity is based off something we taught about last week, and that would be the Glasgow Coma Scale. So make sure you understand if the head injury would be mild, moderate, or severe using the Glasgow Coma Scale. So concussions, when I think about a concussion, you guys, I often think about like football players. I think about people that take risky behaviors, maybe military personnel, like with shrapnel and things hitting them in the head. Reckless drivers put patients at risk for having a concussion. With a concussion, you may or may not lose consciousness, so don't think you just gotta be like completely knocked out for it to be a concussion. But you will have some impaired cognition, so you may have difficulty remembering things or processing information. My son, had the friend that he was playing racquetball with, and they ended up colliding, heads butted together, and his friend had a impaired memory. He couldn't remember he bought a motorcycle. He couldn't remember where extra money came from. And my son called me from college all paranoid, freaking out about it, and they didn't want to call his mom, and I was like, oh no, you got to call his mom. So he ended up calling his mother, and his mother agreed that he didn't have to go to the hospital as long as Dustin stayed and paid close attention to his level of consciousness. Did he have mental status changes? And so she, frequently checked on him. So I don't know, if it had been my kid, I probably would have said, let's go to the hospital or a doctor or somebody to evaluate it besides my non-medical son. But anyway, that was what they decided to do. Oftentimes, what's more detrimental to the patient is not what happens initially with the brain injury itself, but what happens after the injury. So it's after the injury that the brain starts swelling, or we have edema, or we see that the patient's condition really worsens. And that's when we have to really start worrying about it, the impact of how the patient's going to come out, how are they going to survive, and what damage they actually occur. Patients that get lots of concussions, like the football players and military people, they often have what is known as post-concussion syndrome. These patients have very frequent headaches. They start having impaired cognition and dizziness. This is what Demaryius Thomas, NFL player, he died in his 30s, and this is what they said that he had. The thing about it is, they often lead to dementia at an early age, depression, maybe suicidal, even substance abuse. So we got to make sure that we're monitoring patients that do have frequent concussions. They actually end up with degenerative brain disease, but the thing is they don't know that until they are already dead and they do an autopsy. So just being cognizant that this is a disorder and it can lead to death or some very impaired abilities in young people to think about. So I don't know, if your kids play football, is that a good thing or a bad thing? You be the parent, you decide, but it just made me a little nervous. So sometimes with that secondary injury, what happens is we have a compromise in the ability for our brain to get oxygen and glucose, and we know the brain has to have glucose and oxygen to survive. So anything that hinders that from happening leads to poor outcomes. So the brain can actually have bleeding that accumulates inside the brain tissue, and that can be from the initial impact, or it can be secondary where blood starts to build up, and that buildup of blood increases intracranial pressure, which worsens patients' outcomes. Or it could be something like hydrocephalus, where the patient has an inability to absorb CSF, or the blockage of the CSF out of the cranium itself. And when that happens, patients have worser conditions related to the injury itself. So if we think about the brain getting perfusion, we have to understand that if our patient, like we talked about shock or something like that, if the mean arterial pressure goes below 70, that means that the brain is not getting perfused. And also if the patient becomes hypoxic, so if their PaO2 goes to less than 80, how does that affect your perfusion? We know that both of those negatively impact how much perfusion, how much oxygen that the brain actually gets. So it could be that the patient has some clots or something that formed inside of the brain after the injury that decrease the blood flow to the brain, or it could be excessive edema within the brain and causing the increase in intracranial pressure. So when we talk about intracranial pressure, we kind of need to understand how intracranial pressure is regulated. It is regulated by three things, and those three things are the brain itself, how much the mass of the brain, the cerebral spinal fluid, and you know that's changing, it is produced in the brain, and then also the blood. So when one of these goes up, the body tries to compensate by taking the other one down. So if we had a swelling of the brain, then the blood pressure could potentially go down to decrease the amount of pressure inside the brain, or it could shunt CSF to somewhere else. Whereas if the patient had hydrocephalus where they're making too much CSF, then that might cause the patient's brain to start shrinking. So one of those has got to change. They're in a tight closed chamber, and one of them has to change. One goes up, the other one has to go down. So normal intracranial pressure is 10 to 15. If it gets above 20, then the patient is, it's when the neurons in the brain actually start to die, and that's really increases poor outcomes. As intracranial pressure increases, remember that means your perfusion to that area is actually going to decrease. So what if we have a hemorrhage? So we actually have a bleed that's taking place in the cranium. In that case, it could be either a venous bleed or it could be an arterial bleed. An arterial bleed most often is at the temporal bone area, like where we put our hand when we're thinking. That's the temporal lobe. And these patients, oftentimes what happens is we're bleeding in, it's a quick bleed, so we actually notice immediately a change in the patient. So they have these periods where they're lucid and then they lose consciousness very quickly. Whereas a subdural hematoma, we often think about, well, if it's venous, it's probably not as bad as the epidural hematoma is. But it actually ends up having a higher mortality rate because we often don't recognize it. So like my son's friend, they had that whole bump in the head thing together. Had he had a hemorrhage and it was a venous bleed, within the 48 hours, it may have shown up something. It may have been an acute bleed, but it could have lasted or bled really slowly for the next 2 weeks to even several months. So you got to think about like patients that come into the hospital that have had a fall or had a car accident a few weeks ago, a few months ago. Could they potentially be having some type of subdural hematoma? And then you could have an actual intracerebral hemorrhage, like where you actually have blood in the brain tissue that's creating like a tumor. This can be very bad. It can lead to brain edema and increase intracranial pressure. So think about how these things could be similar to like a patient that's having a stroke. What can we do for it? If they lose consciousness, this is a medical emergency. We may have to actually put some burr holes in there where we literally take a drill bit and drill a hole in the patient's head. We may need to put some kind of intraventricular drain in there and that thing as well. So these are just some pictures of an epidural hematoma and a dural epidural hematoma and the subdural hematoma, and you can see it's actually based off where it occurs as far as the layer of the tissue itself goes. So if we kind of look here, there's this layer of the brain right here, and the epidural is above it, whereas over here it is a subdural hematoma, and you can see the lining is on the outside of it. So that's one of the ways that they look at whenever they can tell what's going on with that. Sometimes if the pressure gets too high and on one particular side of the brain, it can actually cause it to push to the other side or either push down. So when that happens, your patient's condition is definitely worsened. If it starts pushing over to the right or the left, like when you see I got a picture that I'm about to show you guys, the outcomes of these patients are really bad. If it has an uncal herniation where it starts shifting down, it starts pushing on the brainstem, and that's really not a good finding. The picture I was talking about, and you can see here that the line should come right down the middle, and you can see how this is being pushed over to one side right here, and that's considered a herniation where it's crossing the midline. And then this also is herniating down, and if we look here, we can actually see where it's starting to push on the brainstem. So I already talked a little bit about hydrocephalus, where we have an increase in the CSF. This can also cause your brain to herniate. It can cause increased intracranial pressure. This can often be caused by the body having the inability to reabsorb CSF, or it might be that there's a blockage, like it's supposed to flow down around the spinal cord, and if there's something hindering the ability for it to flow down, then it starts building up and the patient can have poor outcomes. So what can we do to prevent patients from having traumatic brain injuries? Well, if they're males are at higher risk than females because they often take higher risk as far as what they, like driving fast or playing, aggressively or having sports. They just are known to have high risk behaviors. So males are definitely at higher risk. Also at high risk would be your elderly. So I would be concerned about an elderly. How can we do fall precautions? And so we talk a little bit about like how can we promote health? We can teach patients, teach our community like don't drink and drive, wear your seatbelts, make sure your kids wear helmets when they're riding their bike or skateboarding, riding ATVs and that kind of thing. For elderly, we're definitely going to look into fall precautions. How can we protect patients from falling at home? How can we protect patients from falling in the hospital? And then we want to evaluate, is this patient at risk, using the Morse fall scale? What is the patient's risk for falls? Anybody that comes into the emergency room or into your facility that has a head injury should be screened for abuse or neglect. So make sure that you're aware of that. Ask your facilities if you're not seeing that done. Ask your facilities if that's something they follow. So what's your patient going to look like when they come into the facility? Well, they may be difficult to perform their assessment because what if they are one, unconscious, confused, or combative? And that could be related to the head injury, or maybe that's related to whatever they got in their system, alcohol, drugs, and that kind of thing. They may have some amnesia, so they may not be able to tell you what happened or report what happened. But you want to find out as much as possible, maybe from the first responder that brought them in. How long did they fall? Did they have a seizure? Was there any other things that you should be aware of? Like, do they have eye problems? Do they have seizures in the past, or do they have a seizure during this? What was their hand dominance? And then what was the patient's like? Did they use any drugs or alcohol, or was there any drugs or alcohol at the scene when the emergency responders got there? So two things to think about is the physical assessment. As we assess for intracranial pressure, we're going to talk about that in just a second. I got a really good picture. But we are going to be assessing for that. We're going to be assessing for hypotension because hypotension is going to decrease perfusion to the brain. We want to assess for hypoxemia because we know that the brain needs oxygen, and if we're already low in oxygen, that's going to hinder perfusion as well. Think about those blood gases. If our patient gets too much CO2, then they can actually have vasodilation. The vasodilation could actually cause increased intracranial pressure, whereas vasoconstriction might actually end up worsening the ischemia because of the perfusion. So what are we going to see with increased intracranial pressure? What symptoms might you anticipate for your patients? The first and earliest indication that a patient has increased intracranial pressure would be something that is related to their level of consciousness. So if they have a change in their level of consciousness, that is a very early sign of increased intracranial pressure. If they have a headache, if they have pupillary changes, if they have like rapid eye movement, if the provider looks in their eye and their eye is like swelling, like papillary edema would be swelling inside the eye, or if they have some decrease in their sensory or motor function. So you're doing the Glasgow Coma Scale, and that is a sensory or motor function. Is that decreasing? The patient may have nausea and vomiting. So we have to worry about paying attention to that one, increase in intracranial pressure, but that could also be a sign of increase in intracranial pressure. If you have subtle changes in the blood pressure, if you have changes in level of consciousness and pupillary response to light, this can be very informative to their neurological deterioration. So make sure you're paying attention to your PERLA, that we did in fundamentals, and we pretended like we knew what we were doing, but we really didn't have a clue. I know everybody remembers those days of doing checkoffs and just trying to bluff the instructor by shining your light in the eye and then thinking, Perla, and I'm like, wait, what are you talking about? You didn't even look at those pupils to see if they were equal. Did they react to light? Did they accommodate? So with vital signs, what we have is often the vital sign blood pressure will go up and the pulse rate will go down. And then we have changes in the respiratory pattern, and that's usually not a very good sign with increase in cranial pressure. So what's going to be our priority? Our priorities is always going to be ABCs, so airway, breathing, and circulation. And we need to treat the patient with a brain injury as if they have a spinal cord injury. So for a spinal cord injury, you want to make sure that you are assessing like their mobility. You want to assess for sensory perception. Do they have tenderness to the spine? Do they have like an abnormal head tilt or anything like that? You may want to think about brainstem injuries. What's the brainstem control? The brainstem controls the cranial nerves, is where they come off of, and it also controls their breathing and heart rate. So if you got problems there, then that would definitely be a priority. You may need to intubate. So let's think about spine precautions. For spine precautions, first of all, the primary care doctor is going to be the one that determines when spine precautions are removed, not us. We don't make the decision when to take them off of anything. So we want to make sure that we keep the neck in neutral position, not flex, no extension of the spine. When they bring them to the hospital, they'll often take them off the long board, but the spinal precautions are going to stay in place. We're going to leave that collar on them until we get in a definitive diagnosis. So you may see them off the long board, but we'll still have the cervical collar on. These patients, we're going to make sure we keep them in bed rest, no neck or thoracic flexion. Anytime we try to move them, we're going to make sure that if that collar is off, for sure that we manually control that spine, that we don't let it move. We're going to use what position, log roll, if we need to roll them up on the side to make sure that we are protecting this patient. So if we see Cushing's triad here, that may indicate that the patient is at imminent death. That's a really poor outcome. And what we see with Cushing's triad is you have severe hypertension, you have the widening pulse pressure, and bradycardia. So a couple slides back I showed you about you have hypertension and bradycardia and change in your respirations. Well, the Cushing's triad is a late sign, and it's the severe hypertension, widening pulse pressure, and bradycardia. So for behavior changes, what we often see is the patient has restlessness, irritability, or disorientation. If we see that a patient has fixed pupils, that's not a good sign. These patients are, sometimes you will hear them referred to as blown pupils. They're fixed, they're non-reactive, and they're often dilated. That's not good. So if you were to see that in a patient, not a good sign. But make sure you're doing these. Make sure you're doing your perla. Are those pupils pinpoint? Are they responding? Maybe they're not symmetrical. Maybe one of them is an ovid, or maybe they're just left at dilated. Make sure you're really looking at the pupils going forward. Don't try to fool me. I'm not doing your checkoff anymore. So increased intracranial pressure normally occurs within the first hours to the first 3 or 4 days after an injury, when the brain is starting to swell. Late signs for increased intracranial pressure will be the severe headache, the nausea and vomiting. It can be seizures or papilla edema. So I would write down and figure out what are early signs and what are late signs. We want to catch it early, right? So for our motor response, patients may often have contralateral loss of motor, so the opposite side of where the brain is swelling will start to have some deficits. Maybe they got weakness on that side, or they can't bear weight on that side, or move aside. They may start posturing, and we know that decerebrate is a worsening posturing position than decorticate, and I would make sure that I knew the difference between those. So sometimes when they have an injury, they can actually have CSF that is leaking. CSF is supposed to be clear and not have a color. So if you ever see somebody with fluid coming out of their nose or ear and it's clear and they've had some kind of injury, you could actually put that fluid on a piece of paper. It looks kind of like a coffee filter, and it'll actually make a halo sign. Or you could also check it for sugar and see if it has sugar in it, then it may be CSF. You can sometimes see physical findings such as a battle sign. A battle sign is just the bruise that occurs right below your earlobe, kind of behind it a little bit, like on top of that, almost where TMJ would be. And then you can have raccoon eyes if the fracture or the patient had an injury to the base of the skull. And so in class we talked about how you guys look like you have raccoon eyes and brain swelling when you come in for exam sometimes when you stay up too late. So just think about that with brain injuries as well. When we do our psychosocial assessment, you got to think about, like, is the patient acting like they normally act? Are they having these sudden outrages or sudden fits? Are they all of a sudden depressed? Are they taking risky behavior? Sometimes they'll actually not understand that they have limitations, or so they'll deny their limits and that type thing. I can drive, and they can't even move their legs or something like that. They may have personality changes where they were kind of like an introvert and now all of a sudden they're just real outgoing and talkative. It can also become real aggressive. So you got to make sure you're paying attention to these patients and keeping yourself protected as well. So what is cerebral perfusion pressure? That's the actual pressure that it takes to push the blood into the brain. So it definitely affects the cerebral blood flow. So normal cerebral perfusion pressure is 60 to 100. If your pressure falls too low and there's not perfusion to the brain tissue actually dies. So how do you actually calculate intracranial cerebral perfusion pressure? How you calculate it is if you know the patient's map. So if we know the patient's blood pressure and we know their intracranial pressure, there's a mix between those two, right? So if we had a blood pressure, just say 90/42, and then they had an intracranial pressure of 19. So if we calculated our mean arterial pressure from 90/42, we get a mean arterial pressure of 58. And then our intracranial pressure, we already said, was 19. So if we take the map minus intracranial pressure, so 58 minus 19, and that would give us our cerebral perfusion pressure, which would give us a number of 39. This patient's not doing well at all. So if your blood pressure goes down, your map goes down, your intracranial pressure goes up, that's definitely going to decrease your cerebral perfusion pressure. So you guys can think about it, maybe pause the video and just understand that it's the map minus intracranial pressure equals cerebral perfusion pressure. And if you get a cerebral perfusion pressure of less than 60, that's a poor sign that your patient is having brain tissue die. So for intracranial pressure, patient is at most risk the first 72 hours. We'll be reassessing very frequently. At minimal, we'll reassess every 1 to 4 hours. For the head of the bed, if we have the bed low, like if we have the patient laying flat, that increases perfusion, but it also increases intracranial pressure. If we sit the patient up, that decreases intracranial pressure, but it in turn causes the patient to have decreased perfusion. So there has been some controversy on the position we should put the patient in. The general consensus is somewhere between 30, maybe 45 at the highest, to actually improve oxygenation and decrease aspiration. We're going to keep that head midline. Avoid avoid any kind of hip or neck flexion. We will hyperoxygenate before we do suction, but we really want to keep suction to a minimum. We don't want to hyperoxygenate a lot because sometimes that can lead to oxygen toxicity, and also hyperoxygenation can lead to perfusion, increased blood flow to the brain, which would increase intracranial pressure. Want to keep the lights low. Continue to monitor for increased intracranial pressure. We'll make sure patients don't have fever because fever can increase intracranial pressure. So we might want to induce even hypothermia. Maybe keep them between 89.6 to 93.2 degrees. The first 24 hours, it's real important not to hyperventilate because that's going to influence your CO2 levels. And if we were to have them on a ventilator and we hyperventilated them, gave them too many breaths, the change in CO2 could then change perfusion to the brain. We may want to actually give these patients lidocaine to decrease their cough, so we could give it in the endotracheal tube if we do have to do suctioning as well. So what are we going to do? Our O2, we're going to give O2, airway, breathing, circulation, and these aren't in necessarily any order other than oxygen happens to be first, and that is the first thing we're always concerned about. We want to make sure that we're maintaining a cerebral perfusion pressure at least 60, but greater than 70 actually ensures brain perfusion. Cerebral perfusion pressure, remember, is MAP minus intracranial pressure. And if it gets less than 50, that's really, really bad. So for our interventions, we can manage your blood pressure. We don't want their blood pressure to get too high, but you don't want it to get too low either. We can, fever is going to develop as our body is responding to injury. We just become hypermetabolic, which makes our temperature go up. However, if we don't manage that fever, then we can actually, the patient can get worse. They have a higher morbidity rate. The other thing is ventilating. We do want to make sure that we're maintaining a PaO2 somewhere around 35 to 38 because CO2 is that potent vasodilator that can increase intracranial pressure. And then I already mentioned the lidocaine. And then this is just a YouTube video that you guys might benefit from watching. What drugs can we use for increased intracranial pressure? So we can actually give mannitol, which is an osmotic diuretic. It's a sugar substance. So when things are sugary, remember they can crystallize, and if they could crystallize, that means we got to use a filter needle and filter tubing when we administer it. We want to give it in a bolus so that it actually draws blood from the draws fluid from the brain itself into the peripheral circulation. But whenever we're bringing blood from but fluid from the brain itself into circulation, the patient then becomes at risk for fluid overload. So it sounds a little like contradictory that we're giving a diuretic and that causes fluid overload, but it really may. We may need to give these patients a sedative to keep them calm. We may need to do some opioids, but only if the patient is ventilated can you use like morphine and fentanyl. And you have to be really careful with those because they do decrease the level of consciousness. And how do we know the patient's condition is worsening if we're giving something that decreases level of consciousness? They're at risk for seizures. We're going to talk about seizures in another lecture. So if they are at risk or if they have seizures, we're going to make sure that we have them on some kind of seizure precautions such as phenytoin. And then often they will also get barbiturates to keep them calm and relaxed. So if the intracranial pressure keeps going up, we got to do something to relieve that intracranial pressure or the brain's going to die. What we would do is we could do the burr hole, which I already talked about. We could do a decompressive craniotomy where you actually remove a section of the skull and you leave it off. If you do leave it off, remember that patient's at risk for infection. You want to make sure you wouldn't lay them on the side of the skull was actually removed. If you get them up and make them like they're mobile eventually and you get them to the bathroom or something like that, you want to make sure they wear a helmet anytime they're out of bed. Or you could do a craniotomy where the skull is open and then close back immediately. So you open it up, you remove the blood clot, you remove the dead tissue, hematomas and that kind of thing. Then you put it right back on, and the patient doesn't end up with anything open once you get them back. All right, so we're going to cover brain tumors. If we think about brain tumors can be 3 different ways. They can be benign, and that just means that they're not cancerous. They can be malignant, which means that cancer is the brain cancer itself. This is more common in people between 40 and 70 years old. They can be metastatic, and this is where they actually came, like a patient had a cancer somewhere else, and that cancer through the bloodstream cells moved to the brain, and now we have that same type of cancer growing in the brain. That would be a metastatic condition. They're classified by their location as far as they either can be supratentorial or infratentorial. You got to think that the infratentorial has a worse outcome because they're usually involves the brainstem and structures. They're also classified by what type cell actually was affected that the tumor came from. So you can have like meningiomas, which would be like a benign tumor or something like that. So brain tumor, you can have either a primary or a secondary problem. Some complications associated with that would be swelling of the brain, edema, and inflammation, which in turn would cause increased intracranial pressure. The second thing another thing you got to worry about is these patients, if it's a primary, that will mean that it originated within the central nervous system. So the primary tumor means it came here, it started here, but it doesn't normally move anywhere. A secondary is that it originated somewhere else and then it went to the brain. So that's what it means really by the primary or secondary brain tumor. Some of the things that can cause excess fluid in the brain and swelling would be like SIDH or diabetes insipidus from severe fluid and electrolyte imbalances where the brain just all of a sudden swells. And you guys have already covered those disorders in another content. So we got to diagnose and we got to figure out like what's going on. We're going to look at the size, we're going to look at the location of the tumor, and we're going to look at the extent and the damage that the symptoms the patient's having. So we want to know their history. We were, of course, going to do a full neurological assessment. How can we best identify brain tumors? We're going to look at CTs. We're going to potentially look at MRIs and skull films. And then we also may need to do EEGs to determine the amount of brain activity. We may want to do a PET scan to see if it's a cancerous tumor or not. You may need to do an angiography where you actually see if the tumor is receiving blood and that type of thing, or even a lumbar puncture. But just remember again with the lumbar puncture, you do not do that if you have symptoms of increased intracranial pressure, because again, that could cause the brain to herniate. So what can we do for patients with brain tumors? We can do some non-surgical interventions such as chemo or stereotactic radiosurgery. Chemo is, we can give it orally or IV. We can actually even give it in the reservoir of the cranial ventricle, which is that little space that holds the CSF fluid. We can use surgery where we actually go in and take out part of the tumor or remove the entire tumor if possible. But these things are often not curable, but they can increase the patient's quality of life, and patients can live a good bit longer with some of these procedures done to them. We can do other things as well besides just the chemo. We may give some Tylenol for the headache. We may need some dexamethasone to actually decrease the amount of swelling in the cranium and that kind of thing, and then seizure precautions, and then some type of PPI. You get PPIs for everything. So if you got a patient coming in with a craniotomy, they're going to do that. Then, you got to shave their head, and you talk about what I'm sure the patients are anxious, what the outcome might be, the risk that they're about to face. I mean, they're about to go in there and have their head literally sawed open. So make sure you're talking about the anxiety with patients. And then post-op, make sure that you know what to assess. So, the level of consciousness, any changes in neurostatus, make sure you're checking for aphasia, decreased sensation, so doing those pin pricks and soft touches. And then your perla, make sure you're doing the perla. And these are things that if you notice differences, this will be a need and a reason to contact the provider. So for a brain abscess, that's just an infection in the brain. And how do you think we would treat an infection in the brain? It would be with antibiotics. We would need to make sure that there was an antibiotic that can get to the abscess itself. Some of the things that actually cause brain abscesses would be like meningitis, and we're going to talk about that. Ear infections in adults also can get right in the brain. If you think about where the ear is located, it's got direct access to the brain. Sinuses infections, they're right there again at the brain. Mastoid infections, so if we get an infection in our jaw, that can lead to brain abscesses. So that's why it's so important to take care of your teeth and not let infections go all the way down to the bone. And even sometimes lung infections can abscess to the brain itself. So antibiotics is going to be our primary treatment for this. So I'm not going to read the question to you guys. Pause your video and see what your answer is. And the first answer is going to be B. The second answer will be C. And then your last answer for this one will be A. I hope you enjoyed the lecture, and I look forward to seeing you guys in class. Listen as many times as you like. Thanks.